Good evening, everybody.
Hey, everyone.
How's it going?
Hey, Chad.
What's happening?
Hi, Diego.
Hello, Renee. How are you?
Doing all right. No complaints for now.
That's good.
Night's still
Renee, I think I've seen you in 3 different outfits today. Is that possible?
Maybe. There's my pre-workout outfit and then my post-workout outfit. And then I had to get dressed up for this meeting outfit. So
I like the yellow striped shirts. I like that yellow striped shirt. Was that post-workout? Yeah, that was post-workout. Okay.
For the record, Diego's in his 5th outfit of the day, which is really kind of high maintenance in my opinion.
You have that kind of sweating problem. You have to, though. You know, it's one of those things that you just have to, you know.
I get it.
Yeah. I'm just thankful Zoom doesn't have an odor component to it, you know.
Well, I hear the next release does, though.
Scratch and sniff.
Ew.
I've been in the same outfit for 4 days, so it's a totally different problem, Diego.
Mm.
Steve, is that the smell from the 2nd floor I smelled earlier?
Yeah, you thought we didn't take the trash out. Give people a couple more minutes. Looks like people are still joining. I don't know how many we're expecting, Renee, but
we've got really good attendance tonight.
awesome.
Only like 3 people I didn't hear from. So
Cool.
and everyone else answered yes.
People are starved for a little collegiality, huh?
I thought it was FaceTime with me, but
Yes.
yeah,
Yeah,
collegiality with you guys. Sure.
it is. It's you.
Yeah. I think Steve, actually, you'd be fine to get us started.
Okay, great. Well, welcome everybody. I can't even begin to think when we last got together. So it's been many months and many COVID swabs, I think, since we were all in the same place. So it's actually great to have everyone back together today for the AHP PCP Advisory Committee. I think the plan is to get back on track now, and I think meet every 2 months. So for those of you who don't know me or have joined the committee since, I'm Steve Judge. I'm an internist in the primary care network at the university. I'm also the medical director. And Diego and I are the co-chairs of this committee at this point. And I will walk you guys through the meeting today and try and facilitate. So again, welcome. Please ask questions. Sometimes the best thing to do is maybe put things in the chat box and then I can kind of go through those as they come along. We have a fairly robust agenda today. And I guess to just start, any specific announcements that the AHP leadership had to make before we get into the agenda?
I would just like to take the occasion to introduce Jaina Darlington, who is a new member of the provider relations team to this group. This will be her first adult PCP advisory meeting. Jaina joined AHP in November and came from the Center for Community Health, where she had a lot of experience working with providers in support of their colorectal cancer screening initiative. So we're so pleased to have Jaina join the AHP team, and she's just been a great addition, and just want to let you know that she's here with us tonight.
Well, welcome, Jenna. Nice to meet you virtually.
Nice to meet you guys. Glad to be here.
Excellent. Well, unless there are any last minute announcements or additions to the agenda, I think we'll jump right in. And our first topic today is our first presenter is Kelly Vandermark, who is a certified drug and alcohol counselor. And I think I said that right, Kelly. So I've actually had Kelly's going to talk to us today about something called the SUD-PC program. And I've had the good fortune in the employed network of working with Kelly for a couple of years now. And she's been a super duper important part of our initiative to really improve opioid prescribing and de-prescribing, as the case may be, across the U of R's primary care network. So Kelly, welcome, and it's great to see you.
Yeah, great to see you too. Thank you so much for having me tonight. You guys sound like a fun bunch. You're all ready to get going here. So some of you I may have worked with previously in primary care. I was part of that opiate safe prescribing, where we would often, I'd be called in to help with opiate tapers or benzo tapers. And we've kind of expanded upon that. So I'm with Strong Recovery, and our services, as I'm sure many of you are aware of, addiction services are in full demand with COVID. Unfortunately, we've had a lot of people that are using substances and they're in need of help. So SUD-PC's kind of development, not only with working with primary care to help with safe prescribing, but also to access substance use services relatively quick. So if I can, I just want to share my screen with you guys. And you can see, let's see, let me get this to the slideshow. Let me just switch the display setting. Okay, you guys can all see that all right?
Yes, we can.
Okay, great. So SUD-PC is, we're a mobile unit. Right now there's 6 of us, and I'm hoping to hire 2 more within the next couple of months. So we're a mobile unit of addiction professionals that can be accessed throughout the U of R system. So we are here to meet the patients wherever they're needed, whether it's through the emergency department, through the primary care office, through to wherever it is that they want to come to Strong Recovery. We will meet with them and we'll do an assessment, and we'll kind of determine what would be the best level of care for them. So typically traditional substance use treatment consists of groups and individuals. We're a bit alternative. We're not traditional. We're there to meet with whatever the patient is willing to do. So we often see a lot of patients that may be pre-contemplative, and we're willing to work with them and meet with them to get to the point where they may be willing to take some action on it. So it's been pretty successful. We've been started this in June, and we have been building. I mean, our people are very receptive to this. It's great to see patients right in the hospital or right in the primary care office, and we collaborate with the provider so that we can all come up with a united front on what would be the best team approach for the patient. These are just some of the departments that we've been working with. Definitely the emergency department. So when we see overdose patients, whether it's accidental or intentional, we're going to try and meet with them while they're at their most vulnerable spot and offer them treatment. Whether medications are involved in that or just strictly outpatient, we want to be able to have availability to them so that we can rapidly access treatment. G92 is a new unit. I don't know if many of you are familiar with this, but this is a 10-bed unit. It's a medical unit, but it's for patients who also need a longer hospital stay related to their substance use disorder. So those patients that may have endocarditis or pancreatitis or liver related disease due to their alcohol use, they can come to G92, and we are actually doing groups there, individual therapy. We will connect them to wherever they may be after they complete their hospital stay. And often we hang on to them because we've developed relationships with them, and we'll continue to meet with them individually beyond their hospital stay. So it's been a really great collaboration medically and with behavioral health in trying to bridge that person so that they don't fall between the gaps when they're discharged. We can just kind of continue to see them. We line everything up for them when they're ready to go. We see OBGYN, high-risk pregnant patients. Obviously, they need to be seen right away as a priority, so we will connect them with services. Been working with Highland Family Medicine and Strong Internal Medicine. We've been getting a lot of referrals from both of those clinics. And then, of course, all of you of our primary care offices. And Dr. Nazra has been instrumental in introducing our program with Accountable Health Partners. So hoping to expand the services to all of Accountable Health Partners as well. CPAP, we have an addictions therapist who is there full-time in CPAP because there's so much substance use related reasons that people would be in there. So we try to connect those patients as well. And then we've been most recently working with the liver transplant unit for patients that are either in the hospital or they need to be in treatment in order to be considered for a liver. So it's been great. We've really been expanding our services and the word is starting to get out. We're getting pretty busy. So it's been great. Our team consists of, like I said, the credentialized, it's called a CASAC, which is credentialized alcohol and substance use counselor. And we have addiction psychiatrists that we can link the patients to. We staff all of our cases with our teams so that we know what would be the best level of care for them. We have mental health therapists, physicians, family therapists. We have peer advocates, which is kind of neat too, so that if you are working with a patient who's just not ready to do something like get involved in our services, we can ask a peer to reach out to them and just kind of talk to them a little bit about what the services are that we offer. Sometimes it helps, sometimes it doesn't, but it's worth trying. And so our delivery of care is we meet the patient in the ED, inpatient or PCP office. For those patients that are outside of Monroe County and transportation's a barrier, we will offer telehealth and we can link them to resources in their area. So it's not necessarily just everyone's coming to Strong Recovery. We'll set them up wherever they need to go. If they're in, Genesee County, we'll set them up in resources in that area. We'll go to, Rochester Regional. It's not just limited to coming here to Strong Recovery. We want to access the services wherever we can get them. And then providing medicated assisted treatment, methadone or Suboxone, Vivitrol, whatever it may be. We want to make sure that the patients have access to those medications. This is our team, minus one. Our one CASAC that's in CPAP wasn't able to come in this picture, but we do have a bilingual staff as well, which is really helpful. And one of our peers is bilingual as well. So that really makes some of the patients feel comfortable in speaking in Spanish, obviously, and having access to services. We do have an e-consult that we created. So a lot of times we'll get phone calls from providers that may not know, what's the best way to treat a patient, maybe with Vivitrol or oral naltrexone, or, it's Camprol something, or any type of the medications that Suboxone. So you can contact one of our providers. I'll make sure that you all get a brochure. So our providers are here to talk to you as well. If you had questions regarding medications or you have very complex, medically complex patient, we're here to help with that. Most of the patients that we see are pretty complex, but any controlled substance challenges, I just got a phone call today from someone, they think, they're misusing their fentanyl patches. So it's like what we can brainstorm together to try and say, well, what's the best way to help this person? Like, are they really diverting or are they really misusing it? We can kind of discuss different options that we can help in figuring that out. We do have family members that we can access treatment. You do not have to be a patient here in order to have family counseling. So we do have 3 different family therapists here that we can link the patients to. A lot of times we get, parents who may be really upset about their adolescent or their young adult child that may be using. We want to make sure that they're offered some sort of support to handle that difficult situation. And we do treat adolescents, 14 years old, all the way up to 24 is our young adult program. I mean, we treat all ages, but we do have the adolescent program that I like to let the pediatrics, if you have pediatric patients. Some of you, I'm sure most of you are aware, anyone prescribed over the 50 milligrams of opioid medication, you want to prescribe Narcan. If they cannot afford it, please let me know, and I'd be more than happy to provide a Narcan kit to them. And anyone who may need assistance with opiate tapers, we are still doing that. I get calls on those actually pretty frequently for opiate or benzo or polypharmacy. I mean, there may be multiple medications involved, and it's like, where do we start? So that's still going on. This is how to refer to us. And this phone call, the phone is myself. I'm always answering it. And if I don't, there's email as well. And I mean, it's successful. We want to be able to answer all of the referrals within 24 to 48 hours. And like I said, we'll collaborate with you. We usually like to keep you all in the loop when we do talk to the patient and let you know what's being recommended. I always just throw this in here about our Narcan trainings. We have it twice a month, just so that people are aware. It's Zoom, and it's pretty receptive. We do it for all of public safety and schools, nursing programs. So I just like to let people know that it is out there. It's available. And that's all I have. Do you guys, anyone have any questions about this?
So I'm not seeing any questions in the chat yet, but please raise your hand if you have questions, comments, if you've had experiences with the program that you'd like to share. We have a few minutes.
George, was there anything you would add about the rollout to AHP practices?
Nothing to add. I think Kelly did a great job, but just to reinforce that the internal referrals are Epic based, and that phone number really is for community practices. Like Kelly mentioned, that's a phone line. I've used it many times from the ED or in the hospital on consults, and Kelly is very responsive most of the time. There was a question, Kelly, if you can answer, how does the process work? If a practice has a patient that they want to consult on, they want to access services, and they call you, what do they expect? Same day, next day? How does the process work?
So typically, whenever I get a referral, I will kind of triage it and prioritize it. If it's something, if we need to see them within that day, I will give it to one of the therapists so that we can address it as quickly as possible. So a therapist will then reach out to the patient. So I definitely want you to have that conversation with the patient first. I don't want anyone blindsided. I want them to understand that we are coming into their care on the advice of the provider, and we're there to work together. So if you give me the referral with, the name, medical record, whether you call or you kind of give me a brief scenario of what the situation is, we call, we complete a phone screen, and then we set up an intake appointment. And the intake appointment can be in our office here at Strong Recovery on West Henrietta Road, or we go over to the primary care office. Usually they like to go to the primary care office, and we just like to call the office manager ahead to let them know, hey, we'll be coming. Do you have space for us? And then when we're there, it's great if we can talk to the provider at that time or afterwards, or we just shoot them our note so that they know exactly where we stand. Sometimes our intake involves a toxicology screen. So we would, if we are meeting with them in your office, we would ask that you would put that order in, or if they're here at Strong Recovery, we just do that. So.
Kelly, I have a question. My name is Russell Maggio. this is a breath of fresh air. Pain management. How do you interface with pain management services over at Strong? Quite frankly, they've been a disappointment when it comes to actually managing narcotics and so forth. They don't want anything to do with narcotics or benzos. They make suggestions, but they'll have nothing to do with the prescribing. They're a disappointment with patients. Patients often feel that they're made to feel like addicts from the moment that they walk in. So pain management services, for the most part at Strong, have been a disappointment for our practice and for our patients, for many of our patients. So you're a breath of fresh air, and it sounds great, and I'd love to utilize your services. I'm glad to hear that you're willing to work with us and actually make good suggestions in terms of taper schedules for people that are on high doses of narcotics and benzos. Sometimes we inherit these patients. Sometimes they've, just show up on our doorstep. A lot of them come from neurosurgery or from orthopedics. They're often given, or this is less common now, but they were given narcotics for a while, and then right after surgery, one bottle, and then told, go talk to your PCP about getting off the narcotics. And so we're left sort of holding the bag with many patients. So, I look forward to working with you.
Thank you. I see that a lot. Patients are inherited, and then after a while, it's like we're not decreasing the amount, and the patient may be asking for more, and it becomes really concerning when they're on multiple sedating medications. So I still work with Janine Benzie, who's the pharmacist through the U of R
Yes.
primary care network, and I've had other pharmacists. I think she must share the responsibilities with, that we come up with that taper plan, and it's put right in their chart, and then we work with the patient so they know this is what the taper plan is. Some of them may not ever completely get off, but they may get down to safer doses. And as far as pain management goes, it's tough. I mean, it's tough to know whether someone's misusing their medications or whether there's actual pain. One of our psychiatrists here is also works in the pain clinic. So she does both strong recovery and pain, which is always, she's a great one to consult with because it's dual. And what do we do? You know what I mean? You're going to have someone who is on that combination for a long time. And how do we best address that without increasing their anxiety and pushing them over the edge? You know what I mean? It's like just doing some of these slower tapers.
Yeah, it sounds like you have a great approach. It really does. Very patient centered and very patient first approach. It's really, really, like I said, a breath of fresh air. That's great.
Kelly, there's a question from Dr. Meeker at Victor Health Associates asking, will you go outside Monroe County? And he's right outside Monroe County in Victor.
Yes, we do.
Okay.
Yep, not a
How
problem.
far outside Monroe County?
Well, whoever's within the U of R network, that's kind of where we're at. But
Right.
I mean, I have gone down towards the Wellsville area. That was a popular place for us for a while until kind of things were restructured. But Batavia, Williamson, we'll go wherever. We've got company cars for it, so that's good.
That's amazing. Thank you. All right. Well, thank you very, very much, Kelly and George as well. We're going to move on to our next agenda item, but thank you so much for this.
Thank you for having me.
Bye-bye. All right. Just try and keep us on target here. So I'm just going to turn it over to Dr. Teeters for a quick introduction of our next group here.
Yeah, so thanks, Steve. Many of you may recall we've talked about this at various venues over the last year or more now. Going back now 2 years ago, as we started looking through the variations and cost utilization in our network, we found several things. Number one, that for large joint replacements, specifically knee and hip, we both had reasonable out-of-network leakage. About 30% of cases would go out of network. And when they did go out of network, they were on average, about $4,000 more expensive per case. The patients were more likely to go to post-op rehab and most likely to be readmitted. And then in a retrospective analysis, they were also more likely to have reoperation. So seemed like there was a good opportunity both to curb costs and benefit quality simultaneously. We also knew at the same time that there had been issues previously of getting into the U of R orthopedic joint replacement team, and that sometimes that delay caused people to refer out of network. So we wanted to see if we could develop a process by which we could get patients into care sooner, take a more conservative management approach, ideally avoid need for joint replacement altogether, but get them on an evidence-based management plan, curtail any unnecessary costs, but then also have a direct funnel into the network joint replacement team if and when that was the most appropriate next step for the patient. So Dr. Barford and Dr. O'Born, and there might be a couple others, I don't know if it may just be the two of them with us tonight, are from the non-operative orthopedics team. So they're sports medicine folks who have helped spearhead this development of this non-operative pathway. And they're going to talk to us a little bit about exactly how that pathway is structured, what you as the primary care team can expect from this program. And then also I'll just mention, they have made availability in their schedule. They can speak to it, but they have pretty ample availability to accommodate patients on very kind of immediate access standpoint. We've had about 70 patients go through the program so far. So we're starting to see a little bit of traction and movement in that direction. But this has the potential of millions of dollars of net savings. So huge hopeful improvement for the patient care, hopeful more expedited evaluation by the subspecialty service, and then ultimately triaging them to the most appropriate care. So I will turn it over to Dr. Barford and Dr. O'Born and let them take it away.
Thanks, Dr. Teeters. Really appreciate the introduction. So can everyone see this okay? So this program was initiated by our sports medicine and orthopedics group, and just as a sort of clarification, we really have two groups now as part of this program. That started off with the primary care sports medicine group with Dr. O'Born and his colleagues here, who you may know, and then it was kind of discovered that, you know, us in PM&R, we've sort of expanded a lot in the last few years. I started in 2019, and Kurt and Rondi started, you know, after me, and we're all kind of doing a lot of you know, large joint management, similarly to the sports med docs, with a little less of a sports focus, other than Dr. Lazaro. And so you know, the vast majority of what I see is osteoarthritis of the knee and hip, and so along the way we kind of realized, you know, we really are both kind of working together, both of our groups, and it'd be useful for us to sort of work together on this project and be you know, to essentially be one funnel for the same care pathway. So as a little bit of background, as you probably know, you know, knee and hip arthritis is quite common. Osteoarthritis is the most common joint condition in the world, and it's responsible for a substantial amount of healthcare utilization and financial burden, both with you know, because of missed work, as well as medical care and surgeries, and about 30% prevalence in Monroe County. And as Dr. Teeters mentioned, orthopedics, our joint replacement colleagues have a low-cost, high-quality arthroplasty pathway for those patients who are appropriate for surgery. And they have, you know, they have care coordinators and patient navigators, and they have various ways to manage their costs. And they also have excellent outcomes. And so obviously it's worthwhile keeping these patients in our system. And we recognize, unfortunately, there's a lack of a standardization of non-operative management across the system. You know, it depends on where the patient is seen initially for this condition. And so the goal would be to launch this standardized clinical care pathway so that they get evaluated in a timely fashion. We have recommendations that are evidence-based as far as their non-operative management, and then also surgical optimization, medical optimization for surgery of those patients who do need to proceed to arthroplasty. So if you look at sort of guidelines for treatments for osteoarthritis, there's a number of different organizations who spent time thinking about this. And essentially it all comes down to, a pyramid, just like the food, old food pyramid of care, where at the baseline, basically everyone needs information about their disease, education about, what arthritis is. It's a degenerative condition. It's not not a temporary injury. People who have BMI over 25 can benefit from weight loss. Exercise is beneficial, even though for patients, they're often hesitant because of the pain. And then other just lifestyle alterations to avoid, progression of their degeneration. And then some people may need, pretty much everyone needs some sort of guidance as far as what they can do for themselves, over-the-counter analgesics as appropriate and as, based on their other medical comorbidities, topical medications, other, supplements that may be appropriate. And then some people may need some more advanced treatments, such as, prescription anti-inflammatories, physical therapy, braces, and then less people need injections, and then even less people need surgeries. And so the idea is to sort of catch people here so that hopefully if we can intervene in the things that tend to make osteoarthritis progress, we can sort of keep more people in this bucket and keep more people away from surgery. And so we've known, we've all kind of known for a long time that, if you have some sort of care pathway to provide some sort of standardization for what people are hearing about their disease and what people are getting recommended for their disease, we can increase or improve our outcomes overall. And so, but now that, we also have some evidence to back this up. If we have 2 or more components of these non-surgical, non-pharmacological interventions, it can significantly improve their outcomes. So, self-education, exercise counseling, weight, nutritional assessment, and psychological interventions, which has historically been one of the most difficult things, is the psychological piece. So, the idea would be we would create this established consensus-based practice guidelines, and then use those in the counseling of our patients. And so just going back to the way the current system is, depending on where they enter the system, they may get vastly different recommendations or approaches depending on even someone with the same amount of disease and the same medical comorbidities. And so that leads to, some treatment over here, maybe referral back and forth over here. And then patients may be more likely to go on to sort of higher cost interventions, such as, certain types of injections and arthroplasty, when maybe they could have, started with some lower cost and effective management options and hopefully save them up here. And so the proposed pathway would be, a patient who's been diagnosed with osteoarthritis of the knee or the hip, and then a referral gets placed in the system to this non-operative arthritis team, which consists of our primary care sports medicine and then a group of us in PM&R who are doing joint management. And then from here, we can help to facilitate, an exercise prescription, a referral to therapy if it's appropriate, working with a dietitian if it's appropriate. And then, with recommendations sent back to the primary care doctor, as well as some recommendations for medical optimization for surgery. And then they can always come back and see us for things like, injections if they're appropriate and needed. And then ultimately, when they've failed conservative management, when they are medically optimized and the patient desires surgery, then they end up in the joint replacement surgeon's office. And so it's sort of this triangular approach where, we're sort of we can help coordinate this care pathway to get them through the non-operative management, and then hopefully that's enough. But for those who for those who fail the non-operative management, then making sure they're medically optimized to get to the joint surgeons. And so, some things that some relevant things to think about are, the payers sometimes, certain evidence-based treatments may or may not be covered by insurance. Sometimes there are geographic issues with the patients. If they've had previous treatments, we can't always say, well, this patient should get this, this, and this, because they may have tried some of those things already. And then also based on the severity, there's some management recommendations which are not appropriate for, early arthritis, or some that are not appropriate for advanced arthritis. And so those are some of the things we can think about. And on the non-op arthritis team, obviously we start with a consult note and specific recommendations, and then we can also help them with different types of injections. Potentially group visits is something we'd like to set up, and certain medications if needed. And then on the PCP side, you can help them with sort of weight management, mental health management, smoking cessation, and diabetes management. And sort of this can be a collaboration here. And so I'm going to stop there for a second. And I saw there was a question in the chat, so I'm just going to look. I would have to double check about that, but as far as I know, it would be open-ended. Do you mean, would it be for a single visit or multiple visits?
Sorry, Val Newman here. Yes, the question is, these are people who are going to be needing to be followed over time. And sometimes there's a lot of patients are very unclear as sort of when they can sort of when they can return. Is it for a period of 3 months or 6 months? Just the kind of the clarity of, are they kind of once in the system available just to call and be tracked, or do we need to sort of start over? Because there's a lot of confusion in patients, and I'm wondering how this is envisioned.
Yeah, so typically, at least from my perspective, when a patient comes to see me for arthritis management, I'm following them. I a lot of times leave it up to the patient, because some patients just want to know what's going on and they're not worried about it, and they just want to call me as needed or send me a MyChart message. But for a lot of patients, they want to sort of be followed over time, and I'm seeing these patients once every 3 months or 6 months, depending on early on it might be sooner, might be sending them physical therapy and see them 2 months later to see how that went. But certainly the idea is for us to sort of co-manage from a osteoarthritis standpoint, when there are things that we can help with, and then if it's things that we can't help with, then we either send them on to the surgeons or send them back to the primary care. And so,
thanks.
Yeah, does that make sense?
Absolutely, thanks.
Yeah, absolutely. So I'm going to pass it along to Dr. O'Byrne now, so he can he'll tell you about the rest of this, some other things about this program.
Thanks, Nate. I think that's kind of a good segue too, because hopefully once we look at kind of how we've organized and designed the consult note here, that might help shed some light on how things progressed moving forward after the consultation. Certainly we're open to seeing patients and follow-up, and I would say the real answer to that question is that yes, it's open-ended. But our hope is that we're trying to prevent patients from having to come and see us as frequently. But I certainly wouldn't say that we are not willing to see them and follow up. So here's an example of kind of what our consultation note looks like. We're going to start with assessment and plan. There is certainly a portion to the note in the HPI, which I think is very comprehensive. It's actually quite time intensive to do these visits. We've done some already, and I think the HPI is really comprehensive. But really, the meat of the note, certainly in terms of providing information to the PCPs that are referring these patients, I think this is where we should focus. So we have a little blurb here. Obviously, we just mentioned, we discussed the degenerative and progressive nature of the disease, and that our recommendations are based on evidence. And there's kind of 4 separate sections that we'll go through here. We start with recommendations that are strongly considered with high levels of evidence. So these are things like exercise, self-efficacy programs, weight management, use of a cane, knee brace, over-the-counter medications, and steroid injections. And then there's the next category would be our recommendations that are considered with lower levels of evidence, like the following, CBT, RFA, Tylenol, capsaicin. Go ahead, Nate. And the next would be those things considered but not recommended for initial treatment. So that includes things like viscosupplementation, modified footwear, PRP, acupuncture, and the last category being those things considered but often recommended against. So things like glucosamine chondroitin, TENS units, and hydroxychloroquine. should probably not even say that word these days. And then we kind of come up with like a plan that's customized for each specific patient that takes all of those things into consideration, and kind of lists those things out in an organized fashion. Go ahead. I think we skipped this slide, Nate. Backwards. Yeah, there you go. So, and then we say, we try to summarize here things that we would recommend if the patient fails initial recommendations. So say we recommend the patient work on weight loss and physical therapy and over-the-counter medications and a cane. But if they fail those things, we would consider as a next step, for example, steroid injections. Then we move into like our modifiable risk factors, which we are try to address, this being a standardized and comprehensive note. So things like hypertension, diabetes, if they've had a recent A1C, that's in there, smoking status, and then weight. And then obviously in that previous section in the plan, we kind of make recommendations if the patient has uncontrolled hypertension, recommendations for better blood pressure management, or if they're smoking, recommendations to quit smoking. And this is, beneficial for multiple reasons. But I think the two most important would be these things can help in the management of the disease, right? They can help in preventing progression of the disease, help in managing symptoms. And even if patients are eventually, seeking out arthroplasty or deemed candidates for arthroplasty, these are things that are going to be very important. I think a lot of times we see patients who come in, they're smoking, they have uncontrolled diabetes, and they have end-stage arthritis, and they're overweight. And they're very, very difficult to manage at that point because they're almost out of options. So we're hoping to catch patients, before they have advanced arthritis, while they have these medical comorbidities, and try to manage these prior to the development of severe arthritis, so that when they get to advanced arthritis, they're better surgical candidates. All right, Nate, thanks. So our hope is to provide, a standardized multidisciplinary patient-centered approach, allowing for coordinated care and leveraging some of our existing technologies and systems that we already have in place. We're hoping that this coordinated care can improve our outcomes, decrease costs, increase value of our care, and like I said, address some of those modifiable risk factors for patients who may eventually become candidates for surgery. So this standardized note, we're hoping can provide some evidence-based treatment recommendations, really kind of geared towards and customized for each patient based on consideration for the patient's goals, what they've done in the past, and what some of their comorbidities may be. We're hoping to address some of the potential barriers to evidence-based management of OA care. One of the big ones is obviously PCP workload. I think everyone can appreciate, I certainly can with a background in family medicine, it's difficult to provide comprehensive care for every issue in a 15 or 20-minute visit. So this hopefully provides an outlet for that. We have more time to kind of specifically focus on one issue. It also addresses, sometimes a lack of access, or even a lack of perceived access for patients to resources. Like I said, it addresses medical comorbidities, and again, really provides an avenue for additional time to address those things, which I think is important. And overall, we'll just hopefully improve patients' understandings and education in regards to what OA is and how it's adequately managed. A lot of times patients come in and really don't understand what the best treatments are for arthritis. They're coming in looking for injections or looking for surgery when they haven't really done a lot of the other things that have been proven to be very effective and safer treatments for osteoarthritis. So we're hoping this will be beneficial for everyone involved, certainly patients and you guys as the primary care providers in the AHP network, for several of the reasons listed. It's certainly beneficial to us because our goal is to provide care for patients, musculoskeletal care and getting referrals to treat patients with osteoarthritis will increase our business, right? We'll have more patients. So I think it's beneficial for everyone involved. Go ahead, Nate.
Sorry.
No worries.
Yeah.
So this is just to wrap up. This is a kind of an example of what you're going to see and how to order this. So specifically, you go into orthopedic referral, and you look down in the section here for subspecialty. And we've recently added in the AHP non-surgical osteoarthritis option. So if you're looking to refer a patient into this pathway, you just click that box, put the reason. If you're looking for a specific provider, you can put it, but you don't have to. This will just go into a pool, and then our schedulers will figure out who to schedule it with, whether it's in PM&R or primary care sports. I think for the sake of time, we can just kind of take questions. This is just a summary slide, but we've already addressed all the things on the slide here.
Thanks for the thorough presentation, guys. If nothing else, it seems to me that getting these patients in the hands of a specialist that's talking about nothing but the osteoarthritis from an early stage may have some value, particularly if they, hear the message that weight loss may be able to help them avoid or delay a joint replacement. I think sometimes when referrals happen directly to the joint surgeons, what the patients hear is, you're too fat, you can't have a joint replacement. And I think there's a real potential benefit here to see it as something positive from the patient standpoint. Now, questions from the group. Chad, you said that you've already had 70 people through this program. I'm just wondering, how have they been plugged through that program just so far?
So we did, so starting out, Kim and I worked with Excelis to try to come up with, initially it was a list of patients who had 3 or more visits for a primary diagnosis of osteoarthritis in the last year, who had not seen an orthopedic in the preceding 18 months. What we found is while we got some patients out of that, most of those patients were already so far down the path that they had already been referred to a joint surgeon. So we wanted to back it up sooner. More recently, we've done a poll looking at 1 or 2 visits for the primary diagnosis of osteoarthritis. Obviously, that casts a wider net, but it does seem that we're finding patients earlier in the course. The goal of that was not to make this dependent on a chase list, but rather to get people experience using the program. And then once they hopefully found value in it, then the referrals would come organically. But as we've talked about, and with Dr. Aborn and certainly Dr. Barford, the goal of this is not to be restrictive. We're not here to tell you what the criteria have to be before you can refer a patient into the program. We'd like to be more open and getting patients in. We're also not looking to be restrictive on type of insurance or payer. We kind of want this to be a more holistic approach so that we can really get value out of the program, even though we know from a value-based contracting perspective, it will only be the Excelis and MVP that we will see the contractual savings. But obviously, we think that this is advantageous and better care for the patients as a holistic approach. So we wanted to make it open to everybody.
And just to emphasize that, just to emphasize that point too, we just got data as of 4 p.m. today, the 70 patients Chad had mentioned. And interestingly enough, only 28 of them are contracted and the remaining are other payers. So again, exactly what we hoped to happen, drive all patients into the program. So.
And Renee posted an interesting question, Peter, Nathan, if you can address for referring providers that are not on the Epic system. Can you just talk about how they can refer patients into the program?
So what I had heard was that this would, there would be a specific referral to come through RightFax. I'm not sure exactly the status of that, but I do know if you put in however you would normally refer to orthopedics, whether that be something you print and fax, if you just specify on there, AHP osteoarthritis initiative, it should come to one of us.
Great, perfect. Any other questions?
Okay, can we just clarify that AHP osteoarthritis initiative? I used to just say non-surgical. I would just say knee arthritis, non-surgical orthopedic, please.
That's totally fine.
But that might work.
Yeah.
Or I have to say AHP initiative.
So I would have somebody else clarify that because I may not be 100% on that. But from what I've seen, we've been getting patients just who are referred for knee pain, and we treat them for osteoarthritis as a non-surgical specialist, and they can be part of this program.
And talking to the ortho intake team, I think they're very keyed on AHP, non-operative osteoarthritis. They're looking at that as buzzwords of the patients that are meant to be funneled into this program.
Yeah, I think that's true. And I think if it's close, they'll catch it, my guess.
I think something else that's usually helpful is to like email the actual provider. Nate, you know that I send you emails when I have someone that I want you to see about that. And that always starts a good way to referral program. And same thing with Peter.
Yeah, absolutely.
Yeah, definitely.
All right. Well, I think if there are other questions, maybe we can take them offline. We've got to plug along here. So gentlemen, thank you very much for joining us tonight.
Thanks for having us.
Guys. Thanks for having us.
Thanks.
All right. So now we're going to turn things over to Chad for a little bit here, 3 different topics, but you now have to cover those topics in 15 minutes less than you thought you had. So no, not really. If we have to cut out the last topic, we can. So
no, I can fly through. I'm lightning. No worries. All right, let me pull this up here. And I'll go to slideshow. All right, can everybody see that okay?
Looks good.
Yes, okay. So first thing I want to talk about is our quality performance for 2021. So this is our last calendar year performance. This is the Excelis commercial. This is what we base most of our quality grid on. So you can see blue is the color that we like to see. That means we're at or above the 90th percentile as a network. You will see we have had a couple of metrics where we have not performed as well. Diabetic A1C less than 8 and hypertension has been an ongoing effort, I will say. That is getting more difficult, both because the thresholds get a little bit harder to achieve every year. And we still are anticipating within the next couple of years that the hypertension guidelines are going to become more rigid than the 140/90 where they stand right now. Prenatal and postpartum care were, and even the pharmacotherapy for opioid dependence, those were metrics that we took as collaborative metrics this year with Excelis. These are, as I think we've talked about before, we like to test drive some new metrics so that if we need to take new metrics onto our grid, or if a metric gets replaced in the HEDIS system, we have some other opportunities of things that we've already been kind of test driving or looking at for some time. The depression screen and follow-up, everyone knows that we've been working on this as a clinical initiative. So there is a HEDIS metric. We are not on the hook for that metric. However, we have been following our performance to that metric just so that we can keep that as kind of a downstream goal to one day have the clinical initiative lead into performance on the metric itself. But the good news is for our maximum gain share, we have to achieve greater than 90 points in the contract. So we were able to achieve 109 points for this calendar year, which means we both will receive the maximum or 75% of any savings earned and be restricted to no more than 25% of any loss incurred. So that's kind of the high watermark for us for maximizing our contract performance. Just continuing on, although we do not display all the Medicare and Medicaid measures every year with thresholds, we tend to put front and center commercial, since that's the bulk of the population and the bulk of what we're measured against. You can see that Medicare, always a little bit more difficult, especially with the pandemic. We saw across the country that performance in the Medicare lines of business has dwindled as the elderly folks have been less apt to seek some of the conservative and preventive care. So this is something that we will be looking to re-engage and reinvigorate over the course of this next calendar year. As I'm going to tell you in a bit, we have been able to largely contain the metrics so that we're not going to see a lot of drift, a lot of new metrics on our grid for this next year. And then finally, Medicaid. You can see a lot of red on this one. We did have a lot of, it was New York State's requirement that we had to take metrics across multiple different domains of care. So this was kind of transitioning from the DSRIP program into the value-based care contracting effort. So a lot of those metrics that had been part of DSRIP were required value-based contracting. A lot of these we are taking as collaborative because we're kind of taking them for the first time and taking them for test drives, learning how the metrics function. But you can see we still scored very well overall for our contractual performance, getting not quite to 90 points, but 87.5. So now what folks really care about. So shifting gears into 2022. So this is our updated metric grid for this year that you will be seeing reflected on the Arcadia database. I hope that everyone looks at this and says, wow, this looks eerily similar to what we've been dancing to before. And if you do, the only thing that you will see that should be different is this well care 15 to 30 months. So this is obviously for our pediatricians and family practice providers. The historic well care metrics, folks will remember there was a 0 to 15 months. There was an age 3 to 6, and then it kind of broke down across the age spectrum all the way into adulthood. They have changed, they meaning NCQA and HEDIS, they have changed those metrics to where they are more encompassing of a broader array of age groups than they were before. We intentionally took off some of the well care adolescent, the well child, and the adult well care, because those metrics don't even have thresholds assigned as they've broadened the age range under each metric. This metric has been one that, talking with LJ Shipley and our pediatric colleagues, everyone continues to believe that this well care first 15 months is extraordinarily important. This 15 to 30, you can't take this metric if you don't take this new 15 to 30 component. So we have intentionally set the threshold for performance very low for this year because we're kind of test driving this 15 to 30. We wanted to continue to perform to that first 15 months because clinically, we still think that that's very important, especially coming out of the pandemic, to make sure that these young kids are getting the frequency of care that they need. So the only thing that will be new or different is this well care 15 to 30. Everything else has been on the metric grids before or for some time. And then the points are pretty well distributed evenly for ease of use and reference. So it's a 10-point game for each metric. Any questions about 21's performance or 22's metric grid? Our effort really has been to curb the flux, as I said, but also, we think one of the reasons we pick these metrics is we think that they are important, good quality of care metrics. So that shouldn't change year over year. That should be fairly consistent. Think things that are important to deliver good preventative care should stay important forever. So because of that, we try to contain the number of metrics and the variation year to year in the grid.
Chad, can you just talk about when we expect to see them on the dashboard?
Yeah, and actually, Willie, I'm going to defer to you. Generally, it's in the March timeframe, but do you want to correct me on exactly your go live date?
Yeah, the upgrade is scheduled to be turned on at the end of March 28th.
Okay.
We're starting to validate tomorrow, actually.
There you go. So by the end of March, you should start to see these pop up on the Arcadia dashboard.
And I should give a plug as well for Willie's good work to put the information about these measures on our website. And hopefully you've seen that in the prior year where Willie, you get a lot of detail about the measure, what the exclusions are, even detail about how the various percentile thresholds may have gone up or down compared to the prior year. So that we're hoping to have that information on our website soon. We just decided on this final grid just a little while ago. So, but hopefully those will be up on the website soon. Well in advance, certainly, of the dashboard, I imagine.
Hopefully within the next week.
Chad, you made a comment, and I just missed it. You said that the 15 to 30 month metric, you said you're going to have a low threshold or a low bar. I misunderstood. I'm not sure I understand what you mean. It looks like you got 10 points associated with it.
Yeah, so because the metric has It's brand new. The thresholds are not well established. So Willie in his Arcadia Jiu-Jitsu has set it to where it almost is a report only kind of metric for the year, so that we've set the threshold so low that you almost can't help but to fall over top of it in some way. But we really want to get experience with it and also draw attention to it so that we develop the workflows that will allow this to be more of a functional metric once firm thresholds are established.
Okay, great. Thank you.
Yeah, the threshold's going to be 0.01%.
Oh, okay. So essentially report only. Okay.
Yep.
All right. Thanks.
Any other questions about this? Okay. So we have introduced before, we have intentionally been trying to hone in on our quality metrics because that is the table stakes, if you will, of how we maximize any savings that we earn. But we've also been trying to put more and more attention on how do we bend the cost curve so that savings is as large as possible. So it's really a two-sided effort here. Maximize quality to earn the maximum gain share, and then maximize savings so that number is as big as possible. And so that really is our IPC programs. IPCs are integrated practice committees, as we've talked about before. These are large cross-cutting initiatives, usually have multiple stakeholders, oftentimes have pilot programs that then lead to the broader rollout. But all of these have large anticipated value-based savings attached to them that would contribute to our spend and our overall gain share earnings. So the first in this list is readmissions. I won't go into great detail. Everyone is well versed that we've been talking about this for some time. Our program is the 5 Contacts program. We are well aware that because of the pandemic and because of the Great Resignation and vaccine mandates, that our staffing is as poor right now as it probably has been during any of our professional lives. So we know that there is not extra manpower in the clinics to conduct all of these efforts. So we are trying to take a slightly more, I'll say, conservative approach in the 5 Contacts program. Contacts 3 through 5, 3 is the evaluating the patient within 72 hours after discharge with a phone call from the care manager. 4 is a follow-up visit with the PCP or the designated follow-up provider around 7 days post-discharge. And then Contact 5 for high-risk patients, high risk of readmission. At 21 days, they're supposed to have a follow-up phone call with the care manager. We realize that Contact 5 can be difficult, especially if you don't have a care manager. Contact 4 for our community practices are less easy to track because the visit is happening in your EMR, and sometimes that's not easily mined. Contact 3 is happening within the Epic system. So all of the care managers are documenting this within Epic. So it is the most mineable of all of these, and quite honestly, probably the most critical of all of them, because making sure that patient gets home in the state of care that we thought they should be with the medications that we thought they should be on is probably the thing that is most important in that transitional window. So our focus is going to be to do Contact 3 for all, and then Contact 4 and 5 as able within the practice to continue to conduct the full 5 Contact program, understanding it may not be perfect. The same staffing issues that are affecting us in the outpatient arena are affecting us in the inpatient arena. So having the med techs, the pharmacists, and the discharge coordinators to touch every patient is not going to be perfect, and especially in these next coming months. So we're going to continue to do this because people feel that this has improved our transitional care, but we realize it probably will not be perfect. So we're going to try to focus on those contacts that we think are most critical. Osteoarthritis we just talked about. I'm not going to go into great detail, but we just reiterated the importance of that program and what we're hoping to accomplish. Post-acute care, this was to try to provide that transitional care management both from the hospital to rehab and from rehab to home. This initiative we've had to put on pause with all of the nursing homes and rehab facilities and the staffing issues they have. It is both more difficult than ever to get into rehab. There are some facilities that are not even open any longer. And most facilities do not have the resource to participate in any other initiatives. So we have intentionally paused this because it just wasn't being conducted as well as we would like. And so rather than just try to do something and cause a staffing burden, we decided to pause this for the time being. CT screening for lung cancer. So we had initiated this quite some time ago in partnership with the U of R. Many of you may know they have started a screening program with an APP who is actively outreaching to make sure that the patient meets criteria for screening and then has appropriate counseling and prescribing for smoking cessation if they are continuing to smoke. So we are basically handing the day-to-day operations of this to the UR screening program. And then we will be a feeder program of identifying patients who meet risk criteria once they're ready to take that list on. So we'll continue to be a partner too, but largely taking a sidecar stance with this one with the U of R screening program. For 2022, there are 2 pilots that we are looking at. One is osteoporosis management. So our partners within orthopedics, we have been looking at, but they've been one of the more engaged subspecialty programs. In the last year and a half, there have become a broader array of osteoporosis treatments that have come to market. Many of them are infusion-based and once every few months or once a year even treatment programs. And there have popped up a couple kind of infusion shops of people who are doing this because it's very well reimbursing, even though it may not necessarily be the most appropriate selection for that particular patient. So we're looking to develop a protocol of which patients would be best criteria for which treatments. And then there are specialists, osteoporosis specialists within our ortho AHP program that could be available for referral if that is necessary to determine what the best course of treatment is for patients who may not fit easily within the protocol that we're developing. The final piece is specifically in regard to breast cancer referrals. So we have come to find, and through a little bit of research, and we're still doing some evaluation, that where we send our patients for diagnostic breast imaging sometimes dictates where the patient will receive their post follow-up if they have a positive mammogram or diagnostic breast imaging study. And that can lead to out-of-network care, which is both more expensive and lower quality. So we're trying to put an exact dollar figure and a assessment on what the volume of patients that we're seeing and what the exact delta is between in-network and out-of-network care. But we know that for breast cancer in particular, Wilmot is a very high quality, excellent outcome program. And so trying to keep those patients within network, it will be best for them and best for us financially. So those are the programs that we're looking to pilot over the course of this year. The goal of this really has been to spread the wealth. So we've heard loud and clear that this all can't be on the backs of primary care. And we know most of the spend is within the hospital and the subspecialty realm. And that's why you see that reflected in this list. It's not by accident that this is more subspecialty and hospital based than it is primary care based for that very purpose. Questions about these?
Chad, I'll be interested. I think we had an offline conversation. You know, I think there's one breast imaging group in the AHP community that, as far as I can tell, basically sends all of their abnormal findings to the competition. So I think that's something that we're going to need help working through, because once the patients are there, it's often the primaries don't have a whole lot of say in where the people go for their surgical care. That's been our experience anyway. So
yeah, totally agree. So once we have the data, it makes that a little bit easier to start making issue of.
I'm just curious. Oh, I'm sorry. Was there another question?
Nope.
I'm just curious from the lung cancer screening standpoint. I'd like to get people's input. I happen to be on the steering committee for the lung cancer screening program at the Med Center, and I'm just curious if people are largely starting to take advantage of this lung cancer screening program, or if everyone is pretty much just doing their own ordering and follow up and tracking, you know, setting reminders for yourselves. I think universally in the primary care network, we've kind of done it on our own, but increasingly we have docs who are finding just to minimize risk to some degree of forgetting to follow up or missing follow-ups, they're referring to the lung cancer screening clinic. I'm just curious if people have started to use that group or if it's too new. And if there's any kind of issues or barriers, certainly feel free to let me know offline. I know that's it has the potential to be a very, very good program, I think. So.
And I will say one of the benefits of that group is they do a very good job of finding the most convenient place close to home, close to work for that particular patient that can accommodate. So if they need it after hours, they need it during certain hours, they're very good about plugging and playing patients where the best imaging center will be to get the study.
And I don't remember if it was discussed here, but hopefully people know that people who are down in the southern tier, both Noyes and Jones now have, or not Jones, I'm sorry, Noyes and St. James now have, you can order you can enter people into the lung cancer screening program at those hospitals. They're up and running with the appropriate reads now. So I see some questions here on that topic, actually. I may have just answered it, but.
Yep.
So it was just Strong Highland, Strong West, Morgan-Eyed, but now the southern tier hospitals. I don't know about Jones, but definitely St. James and Noyes are in the mix.
Jones is not up and running yet, but they're planning to be hopefully soon.
All right. And FF Thompson, I'm sorry.
Yep.
Don't want to exclude them. Cool.
All right.
Questions, comments?
We will definitely share these slides. I saw that. So Renee already took care of that one. All right.
Chad, you blew it away. Nice job.
I told you I'd get you back on track. I'm here for you.
It's really good. All right. So
Steve, you muted yourself.
I've only been doing this for 2 years. Last topic tonight is about telemedicine, and really the intent here is to just have a conversation about where people feel they are with telemedicine as we kind of hopefully are exiting the pandemic, where the usage was pretty clear. The value was pretty clear, what people are thinking, how they're going to incorporate telemedicine into their practices going forward if they plan to. I told Renee I'd be more than happy to discuss kind of our strategy at the medical center in terms of the primary care network, where we think we're going with telemedicine. But I think before that, I'd love to hear what people are thinking, what people are planning on, how they're incorporating this going forward. Because I think at the very least, we know that there's a subset of patients who love this and don't really see us ever going away from this. So feel free to share, raise your hands, or I can call on people.
Steve, Val Newman here. I will just say, I hope that we can keep it going because it's incredibly useful for us. When we have patients who call, I can just pop them into a video visit and do a visit right in real time. And they are thrilled. It's fantastic. It's just incredible. It's game changing for us. And I can also stay late and let the staff go home and just run through videos on my own and not have to worry about staffing and keeping people late. So it's just an incredible tool that I hope we can keep that part going.
We will.
Did you see the comment in the chat, Steve?
I didn't. I'm sorry. We need a patient education initiative to help people understand when it's appropriate and when it's not. Absolutely. Ralph, any kind of specific examples of frustrations around that, or?
Well, one example is trying to follow up someone with hypertension, and I want to measure their blood pressure, and they want to just sit at home and tell me what they're getting. I've never validated their cuff against anything else. I need them in the office periodically.
Yeah, I think so. I think that's a a multi-part statement / question there, because I think that's the way a lot of us feel, Ralph. What I will tell you is that the literature really just seems to be evolving to the opposite of that, though, right? Is that the readings that we're getting in our offices are probably less reliable than the readings the patients are getting at home. And I think that on the patient education side, I think that's right. I think what we need, though, is I think personally what I think we need to do is we need to educate patients about having home blood pressure cuffs and how to use them correctly. Because my sense is, and this was John Bisignano before he left was pounding this drum, is that blood pressure is like the only thing we rely on this silly machine in our offices that is arguably really not accurate, even in the best hands. And I think, you know, I'd love to hear, not to put you on the spot, Chad, but I'd love to hear the cardiologist take on this, because my sense is that this is a disease state that is moving very much toward remote monitoring.
Yeah, and I will say, you know, from the cardiologist standpoint, I can always tell how much the patient had pissed off the practice that day, because if they were nice, they had a blood pressure of 126 over 82. If they were kind of a pain in the ass, they had a blood pressure of 164 over 104, because somebody actually decided they were going to take it and really sock it to them. But the number of people, like you could see the same medical assistant who has the same blood pressure reading over and over and over and over again, or, you know, and this was John Bisignano's like most hated thing is, you know, you can sit and watch somebody comes in from the waiting room. I see this in my own practice. They would come into the office, they would stand in line, they would check in, they'd be told to sit down, they'd told to grab their stuff, come back, they'd put them in the office, they'd ask them all these horrible questions about, is anybody beating you? Do you feel safe at home? Are you smoking? Tell me how much weight you've gained. Step on that scale. I'm going to announce it to everybody in the waiting room. And then I'm going to check your blood pressure over top of your jacket, your sweater, and everything else. And then they write that number down and we start managing to it. So I do think, you know, the guidelines now make it almost impossible to do blood pressure and do it well in an average clinic visit. So the patient should be sitting with their arm at heart height for 15 minutes with their feet flat on the floor, not talking, breathing normally, with the cuff on, and then measure it once, wait at least another 5 minutes and measure it again, and then average those numbers. That's pretty much an entire visit for most of us this day and age if we did that. So, you know, I think if to Steve's point, if we could get everybody a well-validated unit that, you know, maybe once every year or two, they stop in, have it checked against a manual reading just to make sure it's getting the same number. But in this day and age, I will say whereas 5-10 years ago, the variation in the home cuffs was so wide that an Omron cuff was totally different than the Rite Aid cuff. In this day and age, they're pretty damn close. I don't like the wrist cuffs, but a brachial cuff is pretty doggone good. So yeah, I generally agree. I almost prefer the televisit for the blood pressure.
But isn't the quality measure we're held to the last in-office reading?
No, so as long as the provider documents it, or a provider's office documents it, you can do it off telemedicine. That was changed in 2020.
Oh, I did not know that.
Yep, so that's now legit.
I think theoretically, or maybe not, maybe it's even written down. I think the patient is supposed to show you their blood pressure, right? Show you the monitor. I think not just give it to you verbally, but anyway.
And some of these actually feed in. I mean, they can actually transmit directly, so it's even easier. You can actually see the digital output of the machine.
So more generally, when the physical exam is going to give useful information, we need to have patients understand that an office visit is still appropriate.
Right. I think that's absolutely. Is that something that this group would want to try and work through? And I mean, I don't know if that's something we've considered, Chad, trying to put out some kind of educational material about telemedicine. I think it is here to stay. I think it's a great idea, quite honestly.
Yeah. I know we talked about it on two veins. At one point, the CMOs for Excelis and MVP had kind of wanted to talk about it as a way to, you know, what is the appropriate time? So if it's a new patient visit, that probably can't and should not be done via televisit. If it's a post depression screening follow-up, that probably is perfectly well done via telemedicine visit. So trying to come up with that kind of rubric of these things should never, these things may be considered the default. And then in between, there's more of that gray area. My only hesitation about being overly prescriptive is that I don't want to handcuff people and suddenly take away what clinically you feel like you could do appropriately. You know, I'm happy to say these, you know, kind of these should never, and these may be better to do over telemedicine, but it's up to you guys.
I think there's an important comment / question here from Christy. I'd love to understand how we can leverage telemedicine, but it's also important to think about the digital divide. And I think this is a real issue, especially as we're thinking about equity in healthcare. And you know, I actually don't know the numbers. I'm sure it's an issue in the poor urban population, but it's a massive issue in the rural communities because the bandwidth is just really problematic in the rural communities. So yeah, it's important. I don't know if there are any grants available out there to try and improve access to telemedicine in the rural areas. I just don't know that.
So we actually have received a telemedicine grant through the U of R. So all of the 3 Southern Region hospitals are both going to have, they'll have parking spots at the hospital that people can just pull up in, but they also will have at least one designated Wi-Fi hotspot that'll be in a community setting, like in a library or the town hall, that people can pull up. It'll broadcast 24/7, so they can actually just pull in the parking lot. They don't have to go into the building, and they can do telemedicine visits there. So there are going to be these opportunities at these community hospitals or in these smaller communities to do that, to at least confine the amount of travel as much as possible.
That's pretty cool.
Yeah, it's very cool.
Do you guys have a sense? I mean, I'm not trying to put a wet blanket on things. Do you guys have a sense that that's something that patients would be eager to use? It's not quite as convenient as sitting in your living room and doing it, but it certainly beats driving to Rochester. Is there a pretty good sense that that's something patients would engage with?
Yeah. We actually surveyed patients, and that was actually considered a very good second alternative. Is just as long as they can drive down the street and not have to get on the highway or go too far, they're okay with that.
Oh, that's great.
Yeah.
I also have to say I've gotten messages from more than one private practice physician in this group talking about payer reimbursement and what are the plans for maintaining the current level of reimbursement, because I think that's absolutely essential for us to continue to be able to deliver care this way. I know a lot of practices wouldn't be able to do it should that reimbursement go back to pre-pandemic levels.
And I will say this has been the drum we've been beating for really ever since the pandemic began. I had this conversation with Carl Cameron from MVP and Steve Cohen from Excellus within the last month. They remain committed that they will continue to fund at parity at least until the state of emergency. But both have said that they understand that this has changed kind of the consensus of how care should be delivered, and that they do not anticipate seeing any significant or maybe any at all change in the level of reimbursement. But they may limit, as I was saying before, like the new patient visit, that they would not reimburse for telemedicine for those types of visits. So I think we're more like, if they hold true to that, we're more likely to see those types of limitations more so than saying the reimbursement rate will drop precipitously from where it is right now.
That's great. Maybe we can keep this on the agenda every once in a while just to get updates from that side of things, Chad.
Yeah.
Great. Are people finding the Zoom? I think most people are using Zoom. Are people finding the technology to be pretty usable? Patients generally finding it to be pretty user-friendly? I know it's not perfect, but
I do. I mean, we use several different techniques for different patients. So we use Zoom or Doxy or Doximity. So there's a whole bunch of avenues that we can use. And if one fails, we can convert to another one. I find Doximity to be very helpful for the person who has a, cell phone and they're in their car, like, from the parking lot of Lowe's, they're, doing their telemedicine visit, So, so I think it's having the ability to go switch from one to the other makes it very helpful. To speak to what you guys were saying about reimbursement, it's going to be important to have a good lobbying group for the Blues and MVP and things like that to kind of solidify that. Last night at the private doctors meeting through MCMS, that came up as well, that they're worried that the Blues are going to kind of force MD Live or force other of their platforms as opposed to our platforms, right? And so I think it's going to be important to be a body of, lobbying for that for our patients.
And I will say both against Carl and Steve, and they seem to have a little bit of, quite a bit of pull within their organizations. Both of them, they want MD Live for those who don't have access to their own provider, but they much prefer it stay within their piece. They understand the value of that. So much so that we actually did have a conversation. Carl Cameron was actually the one who actually connected, and I had a conversation with the MD Live group to see, could we credential all the AHP providers to be MD Live providers if we so chose, so that, it would be one and the same. It wouldn't be going outside of the program regardless. And, largely they didn't really see a value in it from MD Live. So I told them, I was like, if you don't, we'll never use your service. In fact, we will actively advocate against your service. And they kind of said, okay, so that's what we're doing. Don't use MD Live.
Well, I will just to spend 3 minutes just kind of telling people where our minds are at the Med Center on this. There's an enormous digital health initiative going on in the Med Center, and as it relates to primary care, it's kind of a multi-pronged approach. I mean, we've obviously been doing telemedicine the same way you've all been doing it, during this emergency. But we've really been kind of analyzing the opportunities and the threats here. And I think we really do believe that the Amazon Care, CVS Care, those type of things are honest to God real threats. And I think particularly with the younger generations of patients who don't feel the connection to primary care is as important. And they're very much interested in convenience. So we're definitely thinking that an on-demand telemedicine strategy is going to be necessary to really prevent loss of market share. And frankly, to provide better patient-centered care. I mean, we'd rather have the patients coming into having connection with people who have at least access to their medical record than going to Amazon or whoever else is offering this. So we think that we need to do this to remain patient-centered, patient-friendly, consumer-friendly, relevant and competitive against some of these kind of market disruptors. We also see the opportunity here, though, I think, as you guys probably in private practice are all experiencing, the explosion of what we call my chart messages, but whatever your portal is, fill in the blank. It's been, that explosion of those messages has been the single biggest dissatisfier for physicians in our network, for sure. I mean, it's just really extraordinary. And we really see the opportunity, when people go to what we're really designing is when people go to our landing page where they normally would click on my chart and send someone a 17 paragraph question about their 3 health problems, they're actually going to have a choice to do on-demand telemedicine. They're going to have a choice to do what we call e-visits, which are template-driven visits where, where a patient in the past might have called in and just said, I have a UTI, can you give me my antibiotic? They'll fill out a template. It'll be addressed in, within an hour. You'll get your antibiotic that way. But these are very much things that are in development, and we anticipate being live with e-visits in the first half of this calendar year and with on-demand telemedicine by the end of the calendar year. So And that's kind of our thoughts on this. It's, you know, is everyone coming along happily? You know, they'll be kicking and screaming, but it's really what we've decided we have to do to remain relevant and remain, you know, we want the profession to continue, and we're gonna have to move with the times. So that's where we're at. I know we have resources that are, you know, maybe beyond what an individual private office has, but I think it's just important for people to know where we're going. And certainly I'll be happy to share our missteps and successes with the group, because I know there's going to be both. But anyway, just wanted to make sure people were aware of that. All right, well, we're down toward we got 2 minutes left. We can call it a night, or we can tell jokes or whatever. Anyone have a good joke to end the night on? A clean joke?
Don't ask Chad. He's got nothing. That's
I said clean joke.
I was gonna say I'm out, sorry.
Well, this was an action-packed night. So thanks everyone for participation, and guess we'll be back at it in April. Is that right, Renee?
Yep, April 28th will be our next meeting. I will get Chad's slides out to the group. I also sent out an email just a couple minutes ago, the brochure for the substance use disorder in primary care, the brochure to back up that program. So yeah, see everyone in April.
All right.
Thanks, everybody.
Thanks.
Have a good night, everybody.
Bye.
Here, guys.
Good night.